Today, we'll be looking at background to psychological interventions in cancer settings. And we know that not all those who work in cancer settings have the necessary biomedical science backgrounds or are very familiar with cancer and its causes and things like that. And so it's important that we are able to identify, have a working knowledge of what actually happens in cancer settings. And so we'll just look briefly at cancer as a disease that affects different parts of the body. Oftentimes, when people talk about cancer, they look at cancer as a single disease, but actually cancer could be as well over 200 types of diseases, depending on the body parts that cancer could affect. And in terms of etiology, cancer could be a lifestyle disease. There is no 1 + 1 = 2 with regards to what causes cancer, but a whole lot of different things can work together to predispose an individual to cancer. And one of these lifestyle factors that could predispose people to having cancer. And such lifestyle factors could include factors like diet, what people actually eat, smoking cigarettes, taking alcohol, having sedentary lifestyles, where activity levels are very, very low. All of these could predispose an individual to cancer. And then there are also the issues of genetic factors that could predispose an individual to having cancer. And we all know that genetics play an important role in how cancer starts and grows. But of course, it does not mean that all cancers are inherited or have genetic undertones. Genes control the growth and the death of cells. And so a cell's gene contains DNA, a substance that contains all the cell's operating instructions, including the process of normal cell division. Now, mutations can occur, and these are abnormal changes in the cell's DNA. It's like changing the programming language. And so mutations occur because of natural aging, behavioral and environmental factors that are like what I said with relation to lifestyles, then familial vulnerability and other factors that may actually be beyond the scope of this lecture. So mutations occur often in cells, but are usually repaired by the cell itself or cause the cell to die. Cell mutations can be beneficial, harmful, neutral, or neutral, as the case may be. But the underlying thing is that there are some cancers that have strong genetic predisposition. Also, infectious factors could also predispose an individual to having cancers, either infection by certain viruses like the human papilloma virus, Epstein-Barr virus, hepatitis B or hepatitis C virus, and even the human immunodeficiency virus, HIV, are some of the viruses that could predispose individuals to having cancers if these viruses are not treated. There could also be bacterial infections too, like the Helicobacter pylori bacterium that can predispose to stomach cancers. And so the idea is that certain cancers could be caused by infectious factors. And when individuals know that they have this infection, then it is important that they are properly treated for those infections before they grow into more serious conditions like cancer. And so like the human papilloma virus, there are several of them. Over 100, maybe 200 or thereabouts. And some of this human papilloma virus predispose an individual to having cervical cancer or some head and neck head and mouth cancers. And so, but human papillomavirus also does have, vaccines to prevent young children from getting, um, progressing from having the virus into having cervical cancer and things like that. So it's just important that these infectious diseases are not undermined. Hepatitis B and C virus also could, affect the liver, cause liver cirrhosis, degenerate into liver cancer. But if early detected, preventive steps could be taken to reduce the risk to the liver, damaging the liver or causing cancers. So environmental factors also play a role in cancer etiology, and environmental factors would, encompass such things like having toxic deposits in certain areas of our environments, exposure to things like asbestos, within the environment, and all of those carcinogenic agents that are sometimes in the environment that could cause people to have cancer. Sometimes just living under power lines, with the radiations that emit from all of these power lines have sometimes been a source of controversy and concern with regards to origin of cancer. There are also some sociocultural factors that are related to cancer that a budding psycho-oncologist or behavioral interventionist in cancer settings would need to be aware of. And some of these sociocultural factors, relate to the ongoing myths within the particular setting about cancer, its origin, is it contagious, and things like that. And so when a community have this type of perception, for instance, that cancer is contagious, then it becomes very easy for them to discriminate against people who have cancer, to stigmatize them, to want to separate their eating utensils, or for spouses to not want to sleep together or share the same bed. So there are lots of issues that could arise that could be very stressful for the patient, and which could also be a focus for intervention in terms of stereotypes and stigma. And sometimes some families may consider themselves cursed, and because there's cancer in the family, and certain other families may not want to even marry into this family. And so this has strong indications for psychological intervention in cancer setting, both in the hospital setting and at the community level. Another important sociocultural factor that should be understood is the issue of poverty and illiteracy. Because of, that's like a vicious circle. When people are poor, they are unable to get certain good jobs. And when they don't get certain good jobs, they may, when people are illiterate, they may be unable to get good jobs. When they are unable to get good jobs, they do not have money that is needed for healthcare access. And because of illiteracy too, some people may also develop certain lifestyle behaviors that could put them at risk of having cancer. And actually, that cycle can be very, very, can be a vicious cycle. Because of poverty, the person is not eating well. Because the person is not eating well, the person gets sick. But the person does not even have money to access care for treatment. And so it's just, on and on. And so there will be an understanding of the sociocultural, socioeconomic background in which this person is coming from, and what sort of access to support do they have within the community as part of the general intervention that the psycho-oncologist would be looking at to help this individual overcome the challenge in terms of access to care and all of that. Then this understanding provides an important context upon which a psycho-oncologist, the team, would actually plan intervention, psychological interventions or psychosocial interventions as the case may be. Then let's look at the psychological aspect of cancer treatment itself, because a variety of medical interventions are available and are frequently implemented in treating patients with cancer. And all of these treatment modalities have their own side effects, or that can predispose patients to having psychological challenges. And so for this particular topic, the idea is just to provide an overview of cancer treatment and the potential psychological pitfalls that may arise with specific treatment. There are several types of treatments for cancer, but for the purpose of this lecture, we'll just be focusing on surgery, radiation, and chemotherapy, and what they cause, psychological impact on the patient. And so surgery generally is, simply put, is the removal of any abnormal tumor, and it remains the primary method by which solid tumors are excised, by which solid tumors are removed, and often also the primary treatment for early stage cancers. I know in our setting in Nigeria, and perhaps in most African countries or less developed parts of the world, surgery is often feared as what would happen. There'll be the anesthesia before the surgery takes place, and there's that fear of, will I even wake up from this surgery? And so sometimes people may need to seek their pastors or imam for prayers before they go for surgery. And sometimes some people may even refuse, some patients may refuse surgery outright because of the fear that they experience. But really, surgery is like one of the first line treatments for early stage cancer. And I often say that if a patient is even told that surgery can be performed, at least it's a form of good news, because it means that something can still be done. Why? Because in certain other cases, the cancer may be regarded as inoperable. And so, using that line of thought could help encourage patients to actually go for surgery. Now, the length of time and ability to recover from surgery, it involves many factors, including the type and the extent of the surgery. Does this surgery involve the removal of lymph nodes? Are there other pre-existing conditions or complications that this patient has? And so some types of cancer involve only surgery. And from the point of the patient's perspective, the surgeon may be the primary doctor that is associated with that cancer care. Now, following surgery, there are struggles before surgery, but then even following surgery, immediate and long-term response to surgery involves different factors. For instance, does this patient have a pre-existing psychological functioning challenges? Is there pain control? Pain is often, especially in cancer, may be something that actually triggers psychological challenges. And we know that pain is what the patient calls it. It's a subjective experience. And so if pain is not well controlled, then there could be psychological impact. Then the degree to which the patient experiences functional impairments. For instance, does the patient need colostomy? Does the patient have some restrictions in terms of functioning? Can they drive as they used to? Can the woman with lymphedema, as a consequence of mastectomy, can she still carry out her house functions? Family functions, taking care of the family and herself as she used to. This type of functional impairment would have implications for the patient's mental health. And then what type of support does this patient have available from family and friends can also impact. So mental health professionals, within the context of surgery, mental health professionals are also sometimes consulted when patients are struggling with the medical decisions related to, should I go for surgery or should I not? Or in terms of how they are able to adjust to the surgery itself after it has taken place. With regards to major surgeries such as mastectomy, response also varies widely. It is typical, for instance, for patients to mourn the loss of integrity of the body. I've seen patients look at themselves after mastectomy and they'd say, when I saw the scar, I just told myself, this is ugly, right? And that's a challenge. It takes some time to get used to this body amputations and loss of body parts before this may be viewed differently. And there are times that there are questions with regards to, did I really make the appropriate decision to have this surgery done, to have this body part removed? Could there have been some other alternative? These all after even the surgery has been effected, has been carried out. And so some other people may not feel greatly psychologically impacted by their surgery, and this may depend on how well informed we are about this condition, even about their condition before the surgery was done. And so it's just important that before major surgeries are done, that psychologists, psycho-oncologists are invited to discuss the patient's readiness for this surgery with the patients to further enlighten them on the surgery. And this would aid proper adjustments following surgery. Then the other treatments for cancer that is very common is chemotherapy. So simply put, chemotherapy is the use of medication or medicine to treat cancer. And the aim of the goal of chemotherapy is to either kill the cancerous cells to keep cancer from spreading, or to slow the spread of cancer down, or to provide symptom relief. So someone, maybe the person's experiencing pain, or the tumor is causing functional impairments or whatever. So the medicine could just be there to relieve pain, symptom relief, as the case may be. So chemotherapy is usually delivered intravenously using infusion over a period of time from as short as 30 minutes to as long as 14 hours. But there are other methods of delivering chemotherapy, including topically on the skin. And sometimes pills or liquid medicines are taken by mouth, that is oral administration. And this could be done at home. There are also other types, either being injected into the chemotherapy, being injected into the muscles and things like that. The side effects of chemotherapy they vary widely from person to person, and then also depending on the type and the amount of chemotherapy that is used. So a common image that would come to mind when people think about a person taking chemotherapy in terms of side effects would be alopecia, that is hair loss, or someone that is frequently vomiting or experiencing nausea, experience of weight loss, fatigue. These are things people would usually think about when an individual is taking the chemotherapy injection. And there are times when people following chemo, they feel like they are more sick than they were before they started chemo, and that could cause some patients to even want to stop. And when you go online or you listen to some other people talk, they tell you chemo is a poison, you don't use it. And so even before commencing chemo, patients are psychologically disturbed about how they will be affected by this chemo, how they would respond to it. And that could even stop some from taking the chemo in the first place. Anyway, multiple factors really impact how chemo affects an individual, and people respond to it differently. Some people, even after taking the chemo, they are surprised that they are not as adversely affected or express as adverse effects as they had thought of or thought that they would experience. So many factors affect how chemotherapy impacts a person's mental health functioning, including the premorbid psychological functioning of this individual. Was this individual hitherto anxious or depressed and all of that? Then the experience of side effects, the severity of the side effect that this patient experiences in terms of fatigue and nausea could also impact on their mental health functioning. Social supports and the type and stage of the disease are also factors that could impact on the patient's mental functioning when he or she is on chemo. Then some other types of chemotherapy related to steroids or hormonal therapy have been associated with increased risk of anxiety and depression. And so these are chemo-induced anxiety and depression. And so how they will be managed, this should be put in mind. And so in other words, even as a patient presents with these symptoms, it's important to also understand which type of drug is this patient on. Is this a premorbid state, or is this a state induced by the medication that the patient is taking? So many people undergoing adjuvant chemotherapy also have complaints of cognitive loss, especially involving short-term memory and executive functioning. This is often called chemotherapy-associated cognitive impairment, or colloquially is called chemo brain. And it can severely impact everyday functioning, where you forget things, where you've kept things and all of that. It just become a daily nuisance and impair functioning. And so many people that receive chemotherapy have subjective complaints of cognitive loss, depending on many factors, including the type of cancer, the stage and the treatment, and some chemotherapeutic agents cross the blood-brain barrier. And in some cases, an argument can be made for a direct effect of chemotherapy on executive functioning. Other variables could also impact on chemo brain, and such as pre-existing cognitive functioning, though this can be very difficult to assess because oftentimes when a patient comes for treatment, we don't often do cognitive assessment for them so as to know if there will be a decline following the chemo and all of that, because patients are eager, and I think even the clinicians are eager for patients to begin treatment. But it would be good to have an understanding, a baseline of what was the cognitive functioning like before the chemo and then after the chemo. That would give us a better idea of the impact of the chemo on the patient's cognitive functioning. Other variables that may also affect cognitive functioning in patients taking chemo are age. Mostly as people advance in age, their cognitive functioning sometimes decline. And so it could be a factor of older age or genetic vulnerability, as well as, coexisting comorbid issues that has to do with depression and fatigue that are contributing to the experience of cognitive decline in patients who may be on chemotherapy. And radiation therapy is also a therapy that is common in cancer treatment, and you use radiation, describes a form of energy, and the average person, we are exposed to radiation one way or the other every day via sunlight. When we use the microwave, we use our telephones, we use our GSMs, we watch our televisions, we go for X-ray imaging and all of that. All of these are forms of radiation. that can be used for investigations and all of that. Or generally, we have one form of radiation or the other experience, whether we know it or not. So ionizing radiation refers to high energy electromagnetic waves that cause electrons to become detached from atoms and molecules, thus changing their structure. Radiation oncology therapy injures the DNA of cancer cells, which in turn reduces cellular proliferation and or triggers cell death, thereby shrinking a tumor. So in other words, radiation therapy, radiation oncology treatment aims at killing the cancer cells or reducing the size of the tumor. And so there are times when maybe a surgeon wants to have a surgery done, want to remove or excise a tumor, and they look at this tumor as too big, they may ask that radiation therapy be done first to shrink the tumor before they are able to go in and excise the tumor. So radiation therapy can be delivered by an external beam using a machine. It could also be delivered internally by placing radioactive materials inside the body, and we call that brachytherapy. It could also be done systematically by ingesting radioactive materials such as radioactive iodine, or injecting material intravenously that travels to cancerous cells. External beam radiation is often delivered via a linear accelerator where this is available. So, a simulation of the radiation therapy treatment plan is conducted before beginning treatment to ensure that the treatment is reproducible and to create any needed immobilization devices or molds. Plastic molds are used for patients with head and neck cancer tumors to ensure that the patient does not move at all. Now, psychological effects of radiation therapy may be non-existent for some people, and it could be profound on others, depending on our individual differences and individual patient characteristics. So people who undergo treatment that requires them to be immobilized in a way that can feel claustrophobic, confining, or invasive can find the experience very stressful, especially if it is the first time that they are experiencing or receiving this treatment. So radiation treatment typically occurs over a period of weeks, and most people desensitize after repeated exposure. But for the people who are predisposed to anxiety, radiation treatment can precipitate panic attacks and acute anxiety. And so oftentimes with radiation treatment, it's just important that patients are first oriented, like a form of excursion, before the treatment actually begins, so that they know what to expect and they are not unduly anxious as they receive the treatment. So we look at other aspects of cancer that could also impact a patient psychologically, and so the cancer context itself. Now, the chronic, unpredictable nature of the cancer experience presents patients with unique challenges. And so clinical experience working in cancer settings shows that certain characteristics of cancer may increase the chances that patients will respond in certain psychological ways. And one of these characteristics is the silent onset of cancer. When cancer comes, it comes unannounced, and sometimes it comes at a time when the patient is feeling like everything is working right for me. There was a patient that just graduated the top in her class, and before she knew it, she was diagnosed of breast cancer from the blues. And so it comes so silently, so unannounced. And even while the patient undergoes the journey, there's often that fear of, if this cancer can come unannounced, then it can return unannounced. And so, the fear of cancer recurrence sort of lingers, even as the patient, even when the patient's prognosis is excellent, even when the patient is now a survivor who has completed cancer treatment. And so that could be a challenge. Then there could also be that issue of delayed diagnosis, right? Where patient complains about, oh, I'm experiencing this. I am not feeling okay within me. Something is strange. And yet the doctors are saying, for whatever reason, the screening methods are not picking out anything. The doctors are not seeing anything suspicious. And before you know it, sometimes they may be saying, oh, this kind of symptoms you are presenting is not typical for the age and things like that. And before you know it, the cancer is advancing due to delayed diagnosis. And so there is that notion of if the medical profession didn't believe me once, maybe it will not believe me again. And that test upon test and then finding nothing can be very annoying and painful and anxiety generating in patients sometimes. And then the invasive and disfiguring treatment, cancer treatment can be very, very invasive and can also be very demanding on the patients, both physically and emotionally. And I even dare say, even in terms of finance, it can invade even the patient's pocket. And so patients dread the treatment as much as, if not more than, the disease itself. The procedure for the treatment, the side effects of the treatment, the implication, the long and short-term implications of the treatment. Sometimes patients can find them more overwhelming than the disease itself, leading them to question both the process and the outcome, and even asking, is it worth it for me to go through this stress? Is it worth it in the first case? And then the other the other feature of cancer, which is that has to do with multiple losses, is also there in terms of body image, body functioning changes, loss of existential security, the loss of predictability, so much uncertainty with regards to what next, loss of social acceptability, especially in instances where stigma is rampant, and then role changes as part of everyday losses of the cancer patients. And so when cancer comes, it's not just about the body. There are other things that are impacted. There are other losses that the patient experiences beyond just the loss of maybe certain body parts as part of treatment. There are other things, the loss of the knowledge of life as one knew it. All of these come in, often at the same time, and can be very overwhelming for patients. And then the association of cancer with death. This is very common. And oftentimes when I speak with patients and you ask them, what does having a cancer diagnosis mean to them? How do they conceive cancer? One of the things that often come forward is the fact that cancer is linked with death. That cancer is like a death sentence. And so this is like, for some of these patients, their first encounter with their mortality, their first encounter with the fact that we would not be here on earth forever. And that can be something that patients find difficult, especially in the context of limited ability to afford the healthcare costs that would be involved in their cancer treatment. And another thing is the chronic unpredictable course of the disease, right? Where patients are not sure of how long they will continue in treatment. There's so much uncertainty surrounding treatments. Sometimes even when patients, when it seems like things are going okay, and another cancer or the same cancer may just spread to somewhere else, or another cancer would come up, and then thinking about the resources. Where would the resources for treating this disease come from? For how long will it be? So there's a lot of unpredictability. And today, cancer is looked at more as a chronic disease, right? Because of the possibility of recurrence. So these issues are just there. So these chronic observations are supported, in literature by several psychological reactions from patients. And despite that, now we have more people surviving the disease due to increase in biomedical science treatment of cancer. But patients often still experience anxiety, depression, altered body image, and fear of cancer recurrence because of all this peculiar or this characteristic of cancer itself as a disease. So with respect to the diagnosis itself, Roland, 1989, identified 5 illness disruptions common to all patients. All patients at one point or the other experience these disruptions, and one of them is distance. Cancer has a way of impacting on relationships and altering personal relationships, either with spouses or with children or with friends and colleagues that may not fully understand this disease and its implication for infection, or its implication in terms of is it contagious or not. And also because sometimes people, while you love this individual with cancer, people may not be comfortable staying around them because they don't want to do anything that will hurt them more, and because they themselves cannot take on the pain, so they sort of stay away. But as they stay away, the person with the cancer also experiences distress or a sense of being abandoned. And so there's that distance. Then there's the issue of dependence. Dependence versus independence. A person that has hitherto been independent would, suddenly find himself becoming dependent on others. And that can be very, very challenging for the patient, and especially when they are not even sure for how long this would be. Then the third D is disability in terms of achievement disruption. Because of cancer, there could be the challenge of continuing in a line of career or continuing in business. Some people's education are disrupted. Life as the individual knows it, their career trajectory is altered. How they plan for the future is altered to an extent, and that increases that sense of disability and reduced functioning sometimes in patients. And this is especially so in cases where they may now have to be a role reversal, such that the breadwinner becomes the bread eater. And that can be a challenge, especially for men. And I will also say not just for men, because there's a sense of I put this in quotes, a sense of pride and a sense of accomplishment when individuals are able to provide for their own. And then suddenly they now have a disease that limits them in the ability to do this. It could come with some form of psychological challenge. Then the issue of disfigurement. The issue of disfigurement that affects body and sexual image and integrity. Sometimes spouses may find it difficult relating to each other sexually because now they view themselves as no longer complete, as part of who they really are, either because an amputation of body parts has been made, or there is a scar or an obvious tumor, and all of this, affects the person's sense of body integrity, body image, and impacts on the individual's sexuality as a whole. And then the issue of death and existential issues. Existential issues are very, very common in cancer care. And Death is just one of them, but as we go through some of the interventions in cancer, we'll talk more about existential issues in cancer care. But within the context of cancer, these are issues, and perhaps even more, that call for a psycho-oncologist's intervention, that calls for psychological intervention, psychosocial intervention in cancer care.